Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is on childhood depression. And normally, we celebrate Children's Day in a it's our occasion for joy and celebrations and all that. But we thought we should look at this very important aspect of childhood that is increasingly becoming common and is a cause for concern. So we thought it was apt to address an important issue today. I must thank Dr. Vasant for getting Dr. Pritam on board and Dr. Ramesh for introducing me to Dr. Venkateshwaran. Dr. Vasant is not new to Marvelous Medicine. He has been on Marvelous Medicine as a moderator and is also one of our regular viewers. He's a consultant psychiatrist in Chennai. He completed his undergraduation from Mahatma Gandhi Medical College, Pondicherry, and his MD Psychiatry from Amrita Institute of Medical Sciences, Kochi. He's also done a certification course in child and adolescent mental health from the Indian Academy of Child and Adolescent Mental Health. He won the Young Psychiatrist Travel Award in psychiatry at a conference in Taiwan, and also received the Mayan Award in 2022 for his work on mental health. He regularly writes in print and social media to spread awareness about mental health. Thank you, Dr. Vas, helping us put this program together. Special thanks to Dr. Pritam for joining this for joining this session. Dr. Pritam's special interests are as in preteen and childhood psychiatric illnesses. So he's a child and adolescent psychiatrist. He's done a fellowship in child psychiatry from NIMHANS and also completed a diploma in child therapy from London. He has several years of experience and he is a chief consultant at Synapse Mind Care and Synapse Child Development Center at Nagpur and Amravati. Dr. Pritam did his MBBS and MD psychiatrist from Maharashtra, MBBS from GMC Akola, and MD psychiatry from NKP Salve Medical College, Nagpur. Thank you so much, Dr. Pritam, for immediately accepting our request to speak today.
Thank you so much, ma'am, for giving me the invitation and letting me have some good activity on the Children's Day as well.
Thank you so much. Last but not the least, we are happy to introduce Dr. Venkateshwaran, consultant psychiatrist, Department of Child and Adolescent Psychiatry at Kanchi Kamakoti Child Trust Hospital. Dr. Venkateshwaran did his MBBS from PIMS Pondicherry and MD Psychiatry from PSG Coimbatore. He also did his fellowship in child and adolescent psychiatry from CMC Vellore. Dr. Pritam will be talking about preteen depression and Dr. Venkateshwaran will be talking about adolescent and teenage depression. Over to you, Dr. Vasant.
Very good evening. I think it's the right topic that we have taken up for today, being Children's Day, and mental health among children is one topic which is commonly neglected. We tend to believe that children are very immune to mental illnesses and hence we need not worry too much into it. But I think post-COVID, the whole scenario changed. We are looking into a lot of childhood disturbances behaviorally also. So good topic to begin with. And we've categorized it beautifully as pre-adolescent and adolescent age group. Looking forward to hearing from our wonderful speakers. Over to you, Pritam.
Okay. First of all, thank you, Team Marvelous Medicine, for giving me an opportunity to present my work on such an important day. So without wasting any time, let's start our proceedings. Hope the slides are visible.
Yes, Dr. Pritam.
Okay, fine. So let's begin. So on this Children's Day, let's speak on something which is really important and really close to my heart as well. So definitely, as Dr. Vasant has mentioned, when we talk about depression, many of the times we have that feeling that the kids are immune to it. No kid can have any mental health issues. They don't have anything to worry about. They just have to go to school, come, play, and everything is happy go lucky in their life. But this is not the classical scenario. So as we every one of us know, it was thought to be a relatively rare phenomenon in minor population, but now it has been substantiated and it has been documented that childhood depression or per se childhood mental health issues are significant, and childhood mental health issues are far more common. In fact, when we talk about the statistics of all the mental health issues, what we see, whether in adolescent, whether in adulthood, 50% of them have their beginning or they start showing symptoms before the age of 14. So it is a very huge number. 50% is a very huge number, and every one of us in the child and adolescent psychiatry domain are working to reduce this number so that we can overall decrease the burden of mental health issues which we are going to otherwise face in the adulthood. The point prevalence for childhood depression is 0.5 to 2% in pre-adolescent and 2 to 8% in adolescent, and I can guarantee you these are the numbers which has been done in research, but the on ground situation is definitely different if we talk about the prevalences as well. Definitely, when we talk about depression, as we are aware about the depression in adult, but it has a huge impact on the overall development of a child. It can affect his overall social development, academic development, cognitively development, as well as the emotional development. And as I have already mentioned, early onset depression is associated with more lifetime depressive episodes and suicidal behavior than late onset depression. So, definitely, this is a very significant factor which we should consider, and that's why early recognition is essential so that we can deal with this unique population and help them to overcome this struggle in their life. When we talk about the depression or the DSM criteria or the DSM, what we generally follow for diagnosing diseases, it has been categorized into multiple things. But major of the things are a major depressive disorder, then there are dysthymia, then there are DMDDs or mood dysregulation disorders, premenstrual dysphoric disorders, and depression can be because of some underlying medical conditions like hyperthyroidism, hypothyroidism can be issues. Anything regarding type 1 diabetes can be a causative factor for depression or other specified depression. As far as the etiology part is concerned, we always, as a psychiatrist, we talk about a holistic etiological factor, that is biopsychosocial. So definitely biological factors play an important role. The role is also played by the social factors like different environmental factors, how the family atmosphere is, how the parents are dealing with the child, how is the atmosphere at school, what is the peer group of the child, whether there are substance use within the family member, any type of bullying, any type of child abuse is there. So definitely environmental factors also play an important role, and again the psychological factors, the overall coping skills of a child, the stress management, the anxiety management. So definitely when we talk about the etiology, it is multidisciplinary. Genetic factors plays its roles, neurobiological factors plays its role, and environmental factors also plays its role in the causative etiology of childhood depression. So when we talk about the different areas, so when we look at the sagittal section of the brain, we have amygdala, then we have striatal nagra, and the prefrontal cortex, which is most important as far as our cognitive, social, emotional development is concerned. And all these different factors work at different levels, resulting in a depressive episode, which is invariably associated with neuronal remodeling. when we talk about depression, again, when we talk about adult depression, every one of us, whether a general practitioner, whether a psychiatrist, whether a general physician, or for per se for any particular medical stream, we have a rough picture in our mind that the person might have decreased interest. He has made him aloof from everyone. He has started being withdrawn. He's disinterested into the things. He's not able to sleep well, or he's sleeping excessively. He's having a loss of significant appetite, or he's stress eating. So when we talk about the actual criteria that when a person should be, or a kid should be labeled as suffering from a major depressive disorder, so this thing is really important. According to DSM-5, at least one major depressive episode in which there has been at least a 2 week period of either depressed or irritable or loss of interest or pleasure. In addition, there are at least four of the following symptoms that are required to label it as a major depressive episode. So, significant weight loss or gain, that is 5% change in a month, insomnia or hypersomnia, like I have mentioned, psychomotor agitation or retardation, fatigue, loss of energy, feeling of worthlessness, hopelessness, helplessness, or remorse feeling about certain events, inability to think or concentrate, and recurrent thought of self harm, recurrent thought of death, recurrent suicidal ideation, or suicidal plan. So, apart from this, when we talk about depression, we every one of us are aware about the different impairment it can cause in different domains, whether in adult, whether in adolescent, or when we talk about the kids as well. Again, when we are talking about only depressive episode or only depression, there should never have been a manic or hypomanic episode, because the diagnosis then changes into bipolar disorder. And again, the episode should not be attributed to any substance or any medical condition. Again, when we talk about, again, this is a major depressive disorder, what we are talking about. There is a terminology called as persistent depressive disorder, in which all the criteria of the depression should be fulfilled, and it should persist for at least 1 year duration. Again, majority of the symptoms what we have discussed for depression should be present with it. Lately, as Dr. Vasant has mentioned, the COVID has changed the scenario of overall mental health in India, but particularly child and adolescent mental health. And every now and then, if you ask any psychiatrist, this category of patients has increased significantly, or we are seeing a classical picture of disruptive mood dysregulation disorder, abbreviated as DMDD, which is characterized by recurrent verbal or temporal behavioral outburst which is present for more than 3 weeks. So, when we talk about the presentation, classically a school is referring a child, or the parents are bringing the child to us, that he's suddenly his behavior has changed like anything. He's getting agitated, he's getting aggressive, he's excessively addicted to more mobile phone or screen time. He's not interested in talking to us on very small or trivial issues. He's getting agitated, he's getting irritated, his mood is swinging like anything. There is poor academic performance. In the school, he's disturbing other class, he's using foul languages, he's not able to concentrate on his work. And majority of the times he is reporting the child has become so much irritable that it is really a challenging task for us to manage the child. Particularly many of the time in DMDD, we are again seeing that the child is indulged in some kind of substance use, some kind of antisocial behavior as well. So definitely disruptive mood dysregulation disorder is one of an important thing what we child and adolescent psychiatrist has see is being seen significantly post COVID. The duration of symptoms must be more than 12 months without a 3 month symptom free period during this time frame. So, age of onset must be before 10 years old, and diagnosis must not be made before age of 6 years and after the age of 18 years as mentioned in DSM-5. Then other DAs, other specified or unspecified depressive disorder in which there are significant characteristic depressive disorder and all the impairment are present, but it doesn't satisfy or fulfill all the criteria which has been already mentioned. Again, Dr. Venkatraman will be talking about the adolescent and adult picture. But when we talk about particularly teens or pre-adolescent, the picture is more like the same, but one or two distinguishing feature is the irritability part, which the teacher, with the peer group, with the school teacher, with the parents observing, getting easily irritable, getting easily agitated, frequent mood swings, not able to follow the instructions, not able to behave in the same way what he was behaving, and comorbidly, then again anxiety comes into picture, behavioral problems, ADHD parts take some role, conduct disorder can be there. So definitely, but irritability is something which we should be very importantly aware when we talk about pre-teens or pre-adolescent mental health issues. Again, as every one of us is aware, we don't have means again, fortunately or unfortunately, we don't have any particular blood test or neurological investigations to confirm our diagnosis. But majority of the time, the diagnosis with the detailed and good clinical history, we can come to a conclusion and can label a particular child with depression or associated disorder. Generally, it is a common protocol when we treat or when we are considering a depression or a MDD kind of picture in a child or an adolescent, particularly, we just rule out with our basic CBCs and thyroid levels whether the child is not having any comorbid hypothyroidism or anemic kind of picture. Routinely in our clinic, in my clinic, I get an RBS done of a child more than 10 years of age because he is compliant for that particular thing, just to rule out if there is any diabetes kind of thing which is undergoing. Again, we have different rating scales, that is, children depression rating scale can be used, then Hamilton depression rating scale has been used to quantify the severity of depression. Again, diagnosing a child per se with anything, any medical condition or any behavioral oblique mental health issues is always a challenging thing, and you have to keep different differential diagnosis when you are diagnosing a kid with depression. Like I have already mentioned, you have to rule out that there is not a manic episode or hypomanic episode, because if that gets missed, you are making a child land up into serious trouble with your antidepressant medication. You are provoking a medicine induced switch, and the child can land up with some psychosis and other kind of feature. Adjustment disorder, anxiety disorder, these are something which we should be also looking on the background of depression when we are talking about the child population. Clinical approach, like I have already mentioned, a detailed clinical history is really important when we are talking about a child population, looking at different environmental factors, the social conditions, what he are in, whether he is going through any kind of stressful triggers like bullying in the school, parental neglect, parental negligence, abuse by the parents, substance use within the family members. So all these things need to be considered when we are approaching a diagnosed case of depression, particularly with the kids. Treatment, again, can be categorized into three particular phases. Acute treatment, which is generally the initial part of the treatment. Maintenance or the consolidation phase, which lasts for 2 to 6 months. And depending on the improvement or depending on the compliance of the patient, the continuation phase in the 6 to 12 months. So for any particular disorder, whether it is a physical, mental, or behavioral or emotional, we want to reduce the symptom severity as early as possible, because the distress a patient is facing, a child is facing, that's why he's coming to us, and that is the same principle what we are applying into the acute phase. Now, when we talk about the acute phase, it involves multiple factors, not only just the medicine. Of course, medicine will form an important part of the acute phase of treatment, but different things like education materials can help us in guiding what depression is, then modifying the parent child relationship, explaining the parent about the etiologies, why the child is going through this. It is not intentionally or voluntarily the child is behaving this kind of thing, modifying any adverse environmental exposures he might or might suffer, and and at the same time giving a secure environment to the child, making him comfortable that he is being acknowledged, he's being given the time, attention what he is needing, and everyone is, including the psychiatrist, including the parents, psychologist, whoever are in the multidisciplinary team, are taking care of him. When we talk of the treatment, particularly there are three major modalities. One is the medication part. Second is the psychotherapy, which involves cognitive behavioral therapies, REBT, some art therapies, dancing therapies, music therapies. And third, a combination of both of them. And with my overall experience, I feel the combination treatment works better than the individual treatment. Like only medicine or only psychotherapy can't be helpful for a child when we talk about when we talk about moderate to severe depression. Again, the treatment plan, when we talk about milder depression variant or pre-depression variant, can be very different, particularly like what we call it routinely as a counseling session, or a talk therapy session. So definitely, when we structured it as a psychological or psychiatry point of view, the cognitive behavioral therapy basically helps in identifying the difficult cognitive distortion that is leading to the depression and correcting them. Again, we all know that counseling is not like something a magical wind that it will work in 1 or 2 sessions. It is a long process. It takes multiple sessions. It has a protocol in itself, how we should plan about it, how we should go about it, rapport establishing, then judging the overall mindset of the child, then giving him instructions, lifestyle modification, and all those things. The basic principle behind the CBT or REBT, particularly about any behavior therapy, that thoughts create feelings create a typical kind of behavior, and the behavior reinforces that thought. So we need to understand this vicious circle, which we are targeting, particularly when we talk about the cognitive behavior therapy. Then there are interpersonal psychotherapy also, which helps to modify the different dysfunctional communication within a family, the relational problems, and all those things. And again, it is something which is a long process. Pharmacological treatment. Every one of us during our MBBS days has learned about SSRIs, that is selective serotonin reuptake inhibitors, and these are still the first line treatment or treatment of choice when we talk about childhood depression. And of all the SSRIs, what we have, fluoxetine and escitalopram, which is available in India also, have been approved by FDA for treatment of childhood depression. Again, depending on the age of the criteria, some other molecules which are not otherwise approved by FDA, but serotonin, in some cases, fluoxetine also can be tried if the patient is not responding to fluoxetine or escitalopram. The standard dose is 10 milligram, what we start with, and gradually we build up the doses depending on the response of the child, the way the parents give us the feedback what we get from the school. And again, every drug has its own side effects, GI disturbances, headache, tiredness, fatigue can be experienced with fluoxetine. For severe depression like escitalopram, we generally start with 5 milligram. We can go up to 20 milligram when we are talking about childhood depression. So definitely medicine also forms an important context, and that needs to be added in the initial or the acute phase, because every one of us have seen that CBT, any kind of interpersonal therapies, all take some time to show it good results. And till that time, because we Indians are impatient, we want everything just right now in front of us to get recovered. So generally medicine along with psychotherapy is something which we generally advocate. Then again, there are multiple kinds of patient we deal with. There are something like chronic depression, then there are some treatment resistant depression, and the choices of drugs varies accordingly depending on the profile or depending on the previous treatment what he is on. So coming to the take home message, childhood depression is a chronic and disabling disorder. It need some expertise to diagnose childhood depression because it has multiple symptoms and it is not a clear cut picture like loss of interest, loss of mood, not able to study. So it is a very mixed kind of picture and it varies from child to child. It is associated with many comorbid conditions. It is associated with many impairments in overall child development in his social aspects, the way he's communicating with peers, the way he's interacting with his parents, the way he's doing his academics, the way he's developing some relation, the way he's playing something. So every domains are affected in that. And early diagnosis forms the key over here. Like I have already mentioned, if you can diagnose a child before 14, so definitely you are preventing the burden of mental health issues in the post-adolescent age group or the adulthood particularly. So psychotherapy forms an important part. Drug-wise, fluoxetine and escitalopram are the FDA-approved drugs. Sertraline can be considered in certain cases. And the most important treatment modality or the thing which works better rather than an individual kind of thing, combination of both psychotherapy and pharmacotherapy, and it has been proven in multiple research that the combination treatment is better rather than giving an individual therapy. So this was all about childhood depression, particularly pre-adolescent age group. And again, these are my references for the same. And I hope I have done justice to the topic. Thank you once again, Team Marvelous Medicine, for giving me this opportunity to present my work on this platform. Thank you, Vasant. Thank you, Vidya ma'am. Thank you.
Thank you, Dr. Pritam. I think that was an exhaustive presentation. And as for childhood disorders, especially when it comes to depression, is very important. So without wasting further time, I would invite Dr. Venkateshwaran to brief us about Dr. Venkateshwaran.
Thank you, sir. It was a good, wonderful presentation by Dr. Pritam. So I'd like to thank Marvelous Medicine for this wonderful opportunity. PowerPoint visible?
Yes. But
yeah. So sorry, there may be some overlap, but kindly pardon if there is some overlap. Okay. So our topic is next few minutes we will discuss about depression in adolescents. Okay. So depression, roughly, clinically, we generally divide into a major depressive disorder or a dysthymic disorder. Okay. So major dysthymic disorder is little severe compared to dysthymic disorder, which is said to be little more chronic. Unlike child, where the mood fluctuations are not very common, in adolescent, natural mood fluctuations are very common due to the growth, hormonal status, and so many environmental issues. Okay, so they will have lots of peer issues, peer pressure, academic issues. So as they grow up, the random mood fluctuations are very common. They will be very labile, they will be defiant, okay, they will be irritable sometimes, okay. So how do we differentiate depression from the natural mood fluctuations of adolescence? So if we don't recognize adequately, we end up treating more and more adolescents for depression, especially pharmacotherapy. So if there is a mood fluctuations and if there is a significant impairment, like functioning in one or more areas, okay, so academics is declining, there is significant difficulty in family interaction, if there is significant difficulty in peer interaction over a period of time, it is not developmental. The child is doing well in the past, and suddenly, gradually or acutely, the child has developed significant decline in functioning, or adolescent has developed significant decline in functioning. Probably we are dealing with a depressive episode. So this is one key factor which is very important in adolescents to differentiate between the normal mood fluctuations of the age and depressive episode. So see the prevalence. To complicate things, the prevalence of depressive episode itself is very high in adolescence. So a child, generally it is less than 2%. It is not that common in children, okay, a major depressive episode. But if you see, there is a jump, okay, in adolescent, if you see, it increased to 4 to 8%. As Dr. Pritam was telling, what we see is just a tip of the iceberg. There are lots of subsyndromic depressive symptoms which may not qualify for a syndromic depression, that is complete criteria for depression, but significant enough to cause dysfunction. Even though they don't qualify for complete criteria for a depressive episode, there will be lots of dysfunction. So it is going to be very challenging adolescent age. 5 to 10% of the children and adolescent, that is more of adolescent, will have a subsyndromic depressive symptoms. Okay. So clinical criteria, either the adolescent should have depressed mood or irritable mood or anhedonia, that is loss of interest in pleasurable activity. So this is the major criteria. Okay. So the adolescent should have one or these two. Okay. Depressed mood or irritable mood. Unlike adult, many times adolescent will not express low mood. They'll be more of irritable mood. They'll be very snappy. They'll be very irritable and very difficult to establish rapport. We think, well, but most likely so. Okay. Along with that, these symptoms, suicidal ideas or wishing to be dead, or sometimes suicidal attempts, decreased or increased appetite. Okay, it is need not to be low appetite. It can be either increased appetite or a low appetite. Increased or decreased sleep. They will feel like sleeping all the time. Okay, so in that way, their functioning reduces. Low energy level or decreased activity, low concentration, and the depressive cognition, hopelessness, worthlessness, helplessness. All these things are part of adolescent depression. So at least for 2 weeks, if they have at least one major symptoms and minor symptoms, then we can diagnose depression in adolescents. Okay, what is the difference compared to adult? Because of the physical, emotional, and cognitive and developmental stages, since it is a developing brain, we will not get a clear-cut depressive episode like an adult. Most of the time, adolescent presenting to the OPD who are prospectively getting diagnosed as depression, they may not come with a clear depressive symptoms. Many times in regular OPD, in pediatric OPD, they'll come with medically unexplained symptom. They'll come with unexplained abdominal pain, unexplained headache, or unexplained giddiness. Okay, when they evaluate for medical causes, it will be completely normal. Many times the initial referral from the pediatrics is for medically unexplained symptom. And when we clarify the initial session, when we ask them about depressive symptoms as a part of workup, they will not disclose. They'll be very defiant. And they will feel like if they express depressive symptoms, people will think they are lying. Okay, so they are mimicking the physical symptoms. So they'll be extremely guarded. But if you go to history and evaluate, you can see clear dysfunction and there is lots of depressive symptoms. And sometimes when it is very severe depression, acute onset, it will present as dissociative disorder. Okay, so they will present to the emergency emergency, or it will present to the neurology OPD with lots of giddiness, loss of consciousness or seizures, or they cannot walk. Especially when it is severe depression or very acute depression, it may present as a when it is gradually evolving depression, they will present with more of medically unexplained symptom, sometimes school phobia. Okay, this can also be part of depression. They'll be very low, they will not be interested. School, they criticize, suddenly they develop phobia for school. What happens? In severe state, they'll have severe anhedonia, they will not do anything. But in mild to moderate stage, there'll be lots of mood activating behavior. So they will start having gadget addiction. So what parents will understand, the gadget addiction has caused depression. But if you look into it, it is the other way around. They start developing depressive symptoms, and slowly they will be very frustrated. They don't know what to do. They will involve in some behavior which gives them some pleasure, which pulls their mood up. So it will result in gadget addiction. So the gadget addiction here is comorbidity and consequence of underlying depressive episode. So this is other second main common presentation. They will bring adolescents for gadget addiction. If you go deep into it, you may see lots of depressive symptoms. And core depressive disorder. Okay. Again, this will present as unexplained behavioral difficulty, irritability, restlessness, agitation. So, okay, this biological depression can also present with non-specific behavioral problems. So, next common presentation is externalizing behavior. Externalizing behavior, they won't come with a very sad face. They won't come with a very low mood. They won't come and talk with you like, I'm feeling low. I'm not interested in anything. Please help me. It won't be like an adult presentation. Problems, lots of aggression, lots of defiant behavior, extremely snappy. Here, the differential is bipolar, but the symptoms won't be enough to diagnose as a manic episode. So this is another common presentation. So it is medically unexplained symptom or gadget addiction or extremely aggressive behavior in adolescence and other substance abuse. Okay, so previously it was very common. Now slowly this internet addiction is taking over other substance abuse, but still it causes serious enough problems. Okay, they will start using other cannabis and alcohol wherever it is available. Okay. Another clear symptom in adolescent, which is possibly pointing towards depression, is unexplained cognitive decline. Many a times, family will bring them for academic decline. You won't see any other symptoms. They will have a academic decline. In mild depression, the low mood will not be very severe. Irritability will not be very severe, but they will have poor concentration, and it results in significant academic decline over, especially dysthymic disorder. It will present for 1 to 2 years. Okay, it will be on the face value they will look normal, but there will be severe academic decline. And after some sessions, if you go into it, they will express lots of low mood and irritability. Okay, so these are the variations in which adolescents will present, and we have to be like really what your mind doesn't know, your eyes don't see. So we should have a high index of suspicion to diagnose depression in adolescent age because of the very varied presentation. Types, roughly, the classificatory systems, it is either the psychotic depression. Psychotic depression is usually, if you see the family history of bipolar and other major psychosis will be there. It is not mandatory, but it can be there. Okay. And here it presents with more severe depression. This is a depression which present acutely with more severe agitation, restlessness. It will be very non-specific behaviors. And it has a greater long-term morbidity. Okay. So the high recurrence rates, and they will be sometimes on lifelong treatment with antidepressants. And initially, since it is part of, if it is part of bipolar depression, there will be initial poor response to antidepressant monotherapy. And once more and more symptoms are clear, probably we might have to use combination. So this usually, if you diagnose 100 cases with depression, 10% will be part of psychotic depression, which may evolve into one or other major mental illness. And this is very common. Okay, depression with atypical symptoms. Okay, the psychotic symptoms are less common, especially in adolescent age. Here, this atypical depression, increased rejection sensitivity. They will be very sensitive. Previously, they may not be this sensitive, but suddenly they'll become highly sensitive to interpersonal relationship. And nobody can tell anything to them. they will have lots of rejection sensitivity, lethargy, laden paralysis. They keep that is age, but they will not be. They will be tired and lethargic. In appetite and craving for carbohydrate, they will put on weight and increase sleep. Okay, this is very common presentation in adolescent age. Okay, atypical symptoms. And there is something called seasonal affective disorder. If the same season, like for example, November to December, two or more episodes, one particular season, there won't be any symptom in the other seasons, like summer season or spring, there won't be any season. It need not be winter, it can be in summer also, but in the same season, two or more episodes of the same polar, then we call it a seasonal affect. This is disorder, as I was telling, the symptoms will be mild, be more chronic. Here, usually they will present academic decline. Okay, sometimes depression can prodrome of other major mental illness like schizophrenia. Okay, usually they will still decrease in functioning. They will express some depressive symptoms, some way psychosis. They responds to an antidepressant, even counseling, but it will persist for 1 or 2 years to develop clear major mental illness like schizophrenia. Because the onset of this illness is also in the adolescent age, so we have to be careful with this entity. So comorbid condition. So this is about the clinical features of in adolescence. Okay, so it is very common, but not very straightforward. Okay, we have to have a high index of suspicion. Comorbid condition. If you see this, 40 to 90% have one or other comorbid condition. Okay, anxiety disorder. Anxiety disorder sometimes predates depression. Okay, there are many research which says the panic attacks. Okay, before the onset of depression, they will have unexplained panic attack. They will have palpitation, some impending doom. Okay, or they will have general anxiety to either specific anxiety or generalized anxiety, that is free floating anxiety, even before the onset of depression. And they can have a clear, discrete depressive episode later in life. Okay, the anxiety disorders are highly comorbid with depression. Disruptive disorders like conduct disorder, oppositional defiant disorder. Here the disruptive disorders are not part of depression. Okay, there is no onset for this disruptive behavior. They will have depressive episode. They would have come for depressive episode, but this disruptive behavior, like aggressive behavior, very sensitive, touchy in terms of ODD, oppositional defiant disorder, or lying, stealing, not caring about others in terms of conduct disorder that predates a depressive episode. And children with ODD or contact, they have a high risk factors for depressive episode later in the age. Okay, and ADHD, another situation where like we see the incidence of depression keeps increasing. Here, these children will be very lively in their young age. They will be hyperactive, running, jumping. Many a times it normalized, especially in male child. Male child has to be like that. They won't treat ADHD. Initially, the school teachers will love them because like unless it is too severe. Okay, so they will love them. Slowly, as the portion increases, as the academic load increases, and slowly as the behavior is distinct from the peers, the people will start criticizing. So by the time they reach adolescent, they will have lots of negative self-evaluation. By the time the academics would have declined, and the onset of depression is very high. Okay, so they are genetically having ADHD puts them at high risk for depression. Environmentally, they will face lots of stress. Holistically, it will prevent. It will put them in a very high risk for depressive episode. Any disorder for that matter. ASD, especially functioning autism, severe ASD, who's having with children with special needs. Again, depression in adolescent age will present as only behavioral problem. Here they can easily recognize, but here problem is mild ASD where the autism symptoms are not very clear except some social deficits, or high functioning ASD. Again, you will not see any other poor symptoms of autism except some rigidity in thinking and poor social skills. Here, these are the children almost invariably will present with depressive episode. Okay, because they will have high peer bullying, they will have high stress in school. People will think they are rude. People will think they are very disruptive, and they will criticize. And these children will have high incidence of depressive episode. And substance use disorder, as I said, it is highly comorbid with depressive episode. These developmental and psychiatric disorders or depressive episode, especially in adolescence. So differential diagnosis, if adjustment disorders, again, if there is a clear life event, a death of a or loss peers, if there is a clear life event followed by depressive symptoms, then we have to consider the diagnosis of adjustment disorder. Psychosis, again, it is very tricky, usually presents with decreased functioning, vague depressive symptoms, vague psychotic symptoms, not responsive for treatment over the years. Then probably we have to think prodrome of psychosis, which is very common in adolescent age. Bipolar depression, again, a percentage of depressive adolescent presenting with depression, they will go on to develop bipolar disorder later. Here, the depression will be very distinct. There will be a clear episodic pattern and more severe and will have psychotic symptoms. Then you are probably dealing with bipolar depression. Okay. Here, especially for clinicians, when you suspect the adolescent will have bipolar disorder, when you treat with antidepressant, you have to warn the family member that this switch is possible. Otherwise, what will happen? You will start treating with antidepressant, and suddenly the child will switch, adolescent will switch to mania, and people will think that you have induced mania. So you have to warn them. A percentage of depression will go on to develop bipolar disorder, whether you treat or not. Okay, sometimes the treatment may accentuate or show the symptoms early, but invariably, adolescent prone for bipolar disorder, they will go on to develop manic episode at some point. Okay, so when you treat depression, you have to warn, especially when you suspect bipolar depression. Here, the differentiating feature will be very acute in onset, more severe symptoms, especially they will be low, dull, not interacting, or catatonic signs, psychotic symptoms. Then you have to suspect bipolar depression. Medical condition, as Dr. Pritam was telling, hypothyroid, vitamin B12 deficiency, low hemoglobin. Okay, all these things are differential for depressive disorder. Again, if you suspect clinically warranted, you have to go on to evaluate. I had an interesting girl like who just presented with depressive symptoms, acute onset depressive symptoms for 1 week. Okay. Here, there is no other localizing signs except one episode of incontinence. Okay. And because of the incontinence, like she was referred to neurology. We got, to our shock, like we got double antibody positive autoimmune encephalitis. Then the girl started developing one after another localizing signs. They become mute, comatose, started developing extrapyramidal symptoms. She was admitted in ICU. Here, since we have identified early, like the treatment was autoimmune encephalitis management was initiated early, and that girl had a very good outcome, completely recovered and without any functional deficit. Sometimes these depressive symptoms or psychotic symptoms can be a precursor of a neurological illness, but it is very rare. The clue here is if you see any localizing signs or localizing symptoms, probably you have to suspect a medical condition and get the appropriate referral. Substance-induced mood disorder is very common, especially even a medical treatment like steroid treatment can cause depression, or psychoactive substance can cause depression. Premenstrual dysphoric disorder sometimes can present as depressive episode. So these are the differential diagnosis that has to be considered in adolescent with depressive episode. Course, if you see the median duration is 8 months, but it is highly variable, especially in adolescent age, it's highly variable and with a very high risk of recurrence. Okay. So if you see this very scary percentage, up to 60% will have recurrence by 1 to 2 years. Even they improve by 2 years, at least 60% will have recurrence, and almost 90% of them will have recurrence by 5 years. Okay, so it is very highly recurrent episodes, which can cause lots of morbidity. Okay. This number is quite inflated. Usually we say 10% will go on to develop bipolar, but in adolescent, there is a higher risk of developing bipolar. Earlier the onset, you have a higher risk of developing bipolar disorder. Okay. Dysthymic disorder will have a protracted course with a very long period, 3 to 4 years. And most of the time, this is misdiagnosed. Why it is very important? These adolescents with dysthymic disorder, they are often misdiagnosed. They will say the age variation or etc., life stress, etc. and they will have significant morbidity. Even though the symptoms will be mild, here the morbidity is more. Okay, so this is a common course that is seen in a depressive disorder in adolescence. So treatment divided into acute phase, continuation phase, and maintenance phase. Acute phase, our aim is to either psychotherapy or pharmacotherapy achieve response or full symptomatic remission. Okay, there has to be response as a clinically meaningful response or a remission. So this is acute phase. If you are choosing psychotherapy or pharmacotherapy, acute phase, the symptoms has to be responded. The whatever the gain you had in acute phase, you will consolidate in continuation phase. You see, the acute phase will be usually first 3 months of treatment, then followed by the second 6 months. Next 6 months will be continuation phase. So any episode you see, like the treatment has to be go on for 6 to 9 months. Okay, then followed by a maintenance phase. Whether we are going to, especially pharmacotherapy, whether we are going to continue for a longer time or maintenance phase, say 2 years, 5 years. So where are the situations? What are all the situations we consider maintenance phase? Multiple episode, 2 or more episode, or severe episode, or episode with psychotic symptoms, or severe suicidal behavior. So these are the situations we consider a treatment, especially pharmacotherapy, beyond continuation phase. If it is mild episode, quick remission, and they're doing well, and think first episode, then probably we'll stop with the continuation phase and just follow up. Okay, so these are the phases of treatment in depressive episode. So initial management, this is very important, psychoeducation involving both family and school. Many a times the presentation, the parental attitude will be that they are lying, they are telling this because they want to escape from studies. Who is not having stress? Everybody is having stress. Nowadays, it has been exaggerated. Nowadays, people are people are creating mountain out of a molehill. All these things are attitude that is commonly seen in schools and family. So unless we educate about the serious nature of the symptoms, the family will not understand, and it is not the easy task. Next level is supportive management. Active listening and reflection of that problem. Many times, adolescent, what they need is somebody acknowledge that, yes, you have pain. I'm there for you. Okay, we will do it together. Okay, this active listening and reflection sometimes resolves 50% of the symptoms. And giving them hope about it is not the permanent situation, and you will be definitely out of it. And teaching problem solving and coping skills, because when they are depressed and when their demand also increase in adolescent age, they will have significant difficulty in problem solving skills and coping skills. If you empower, if you improve their skills through basic counseling, they will be able to negate the depressive episode, and sometimes this itself will help to overcome the depressive episode. As maintaining participation in treatment, again, sometimes they lose hope and they will discontinue treatment. We have to find out strategies to for continuous participation in treatment. So this is the initial management. Okay, educating the family members, making them aware of the problem, and supportive management. Patient with mild depression or a brief depression, sometimes the initial supportive treatment itself will help. Okay, absence of clinically significant suicidality or psychosis. Start with supportive therapy, improve their problem solving skills, observe response for 4 to 6 weeks. If they have achieved remission, then probably no need to go into further management. If they have not responded, they are not responding to the initial supportive treatment. Again, as I said, if it is only mild depression, if it is moderate or severe, the supportive treatment is important, but it is an adjunctive. You have to go for a specific psychotherapy or pharmacotherapy, depends on the situation. Okay, I'm talking only about mild or a brief depressive episode. You can wait for 4 to 6 weeks with supportive therapy and see how it evolves. But if there is no response, even in mild depression, either go for a specific psychotherapy with expert opinion or a pharmacotherapy. Okay, depends on the clinical situation. So specific psychotherapy commonly used include cognitive behavior therapy. Pritam has explained very beautifully. Interpersonal psychotherapy. Many times adolescent interpersonal problems leads to severe depression, and sometimes the depression will create lots of interpersonal problem. So the interpersonal psychotherapy also helps in specific situation. Psychodynamic therapy, it is very exhaustive and it involves 12 to 18 sessions and continuous resource intense and time intense therapy. It is not commonly used, but in select cases it is used. But commonly used is cognitive behavior therapy, interpersonal therapy. If it is associated with personality disorder, dialectical behavior therapy. So these are the commonly used psychotherapies in depression. In mild depression, if they are not responsive to supportive treatment, use specific psychotherapy. In moderate to severe depression, again, severe depression, usually you have to go for a pharmacotherapy. In moderate depression, you can use a specific psychotherapy. If there is no response, you can go for pharmacotherapy. In severe depression, especially very acute, very severe psychotic symptoms or recurrent depression, okay, they keep getting depressive episode one after another, probably go for pharmacotherapy and use combination treatment, adjunct psychotherapy, including supportive therapy is adjunct, because as Pritam was telling, the evidence is more for adjunct psychotherapy with pharmacotherapy. Okay, so these are specific psychotherapies we practice. Pharmacotherapy, these are the drugs commonly used in adolescents. SSRI, first line, fluoxetine, escitalopram, sertraline, fluoxamine. Again, paroxetine and citalopram is not commonly used nowadays. SNRIs, as more and more it is coming to a limelight, venlafaxine, desvenlafaxine, because as they grow in children, all these neurotransmitters has not developed completely, but by the time they reach adolescent, it's almost like an adult in terms of pharmacotherapy. Okay, and another norepinephrine agent, metazapine, tricyclics is generally not used in adolescents for two reasons. One is it has lots of cognitive side effects. They will have excess sleep and because of anticholinergic cognitive side effects. Second thing is they are at high risk for suicide. And if they take the therapeutic index of SSRI is very high. Okay, even if there is an overdose, usually they will come out without complication. But if you give tricyclics and clomipramine, if they are overdosed, it is lethal and sometimes you may not be able to save them. So keep this as a last resort. Use it only in treatment resistant cases. Don't use for as a first line agent. Okay. So commonly used are SSRIs followed by SNRIs. Okay. Psychotherapy, severe depression, go for SSRI. There is no response to first SSRI. They have not responded to first SSRI. Try SNRI, that is venlafaxine or desvenlafaxine, or another SSRI which is not used. Again, if there is no response, combine SSRI with psychotherapy, a specific psychotherapy depending on the clinical need. Again, if there is no response, augmentation with the atypical antipsychotics commonly used is aripiprazole or risperidone. If there is no response, go for clomipramine or lithium augmentation. Okay, so this is the protocol for resistant depression. If they are not responsive to the first line agent, if again RTMS can be used in treatment resistant depression. ECT can be used in severe depression where they are having self neglect. They are not eating. They are very aggressive. Okay, ECT can be used as a primary treatment modality. Okay, so it is depression. Any discussion on depression is not complete without talking about suicide. Okay, nowadays we see in media and news like there are more and more suicide has been reported. Okay, so we have to evaluate risk for suicide for any adolescent presenting with depression. If there is a family history of suicide, poor support system, especially neglectful parenting style, access to lethal means like medications or invested firearms, psychiatric illness, severe psychiatric illness, or chronic medical illness, depression associated with chronic medical conditions like asthma or type 1 diabetes mellitus or psoriasis. Okay. And recent stressful life event. Okay. When they are depressed and suddenly they have a life event, then this puts them at a very high risk for suicide. History of physical or sexual abuse. And this symptom, especially when they have impulsivity and severe anhedonia, they are hopeless. Okay, you can easily observe from their attitude. They will not be concerned like, there is nothing for me. See, I'm not going to do well. Okay, when these symptoms are there, you have to be very cautious. We have to explain suicidal precautions to the parents. And the monitoring has to be frequent. your reviews has to be frequent till you feel the risk has been reduced or risk is less. Okay. So watch out for suicide because it is alarmingly increasing. Okay. So thank you. So this is an overview of adolescent depression and treatment. So probably we will open for questions or discussion.
Yes.
Mhm.
Thank you, Dr. Venkateshwaran. I think you very well explained how adolescent depression is different and what all we should be looking at. Just a couple of we've been talking about SSRIs and pharmacotherapy and psychotherapy. Just to begin the question answers and to open. I've been reading a lot about gut microbiomes, the whole gut brain axis, and how the gut microbia is. There's a lot of research wherein in childhood depression the microbial product itself is very different. There is less biodiversity, a lot of inflammatory markers present and all that. So your take on that, or could you throw some light on that? Anyone, I mean, Venkateshwaran and then Pritam too can add in later.
As of now, there is a
But
very
can I
huge.
just interrupt, Dr. Venkateshwaran, if you can just stop sharing your screen so that we can see everybody on the.
Yeah. Yeah. So as of now, there is a very significant number of research going on in autism and ADHD, where they claim that all these organisms helps in the improvement in behavior. And there is a study done by M.K. Nair from Kerala that also says it has a reduction in irritability. But as of now, sir, like we are not using any gut microbe for treatment of depressive episode per se, and none of the guidelines recommend for the routine use in clinical practice.
Yeah,
So
and
right
more of
now,
the research base is what is
yeah.
it?
Yes, sir.
Pritam, would you?
Yes, definitely. As Dr. Venkatraman has already added, again, when we look at the research part of it, it looks very attractive to us that just adding some pre-probiotic can help to get over the depression and all those things. But yes, research and a clinical picture are not collaborating right now. Majority of the research is directed towards autism, but yes, in depressive disorders or mood disorders, they have also mentioned that the role of pre-probiotics or gut microbiome flora also plays an important, but it's too early to comment on that particular thing. And again, if someone is really affording, because a sachet what they mentioned about the gut microflora and all those things cost 80 or 90 rupees, and it has to be given in a BD dose. So something who is really affordable for that, we can at least consider. But again, in the patients whom I have given the samples provided by pharma and here, I have not seen any significant change by adding those things rather than our conventional treatment modality, what we can do. So as of now, I can label it as a fancy treatment. But yes, time will tell us whether we can recommend it or whether we can discard it.
True. I think one of those questions is also on that, the role of fecal transplant, that is that microbia, FMT, that microbial transplant. The role seems to be very primitive, as in it's a very research based, and it's a very few. And I think only in the US, there's I read a couple of trials at Texas, somewhere else also. But in India, I don't think there is a ongoing clinical trial for FMT. But as Pritam was saying, it is very fancy. And as psychiatrists, when we talk about transplants and all that, it does look fancy. But I think it is time to tell the role of the transplant as such.
Dr. Basan, there are
There
some.
is another question.
Yeah.
Again. Yes, ma'am. Yeah.
No, just
So there is been about adolescence and ADHD, and what its collaboration with autism or depression. What does it mean? So, Pritam, could you talk about? Would you be able to take that question about being
Yes.
adamant and ADHD? Does that mean autism or depression?
No, definitely not. These are altogether different phenomenon. When we talk about ADHD, when we talk about autism, depression, yes, all these three can be associated with each other, can come as a comorbid illness with each other. But when we talk about the specificity of a particular disorder, ADHD has something to do with the hyperactivity of the child, the inattention, the impulsiveness. Autism has do with the poor attention, poor eye to eye contact, not able to make social interaction, repetitive behavior, and depression, what we have talked about. Yes, all the threes can be a comorbid condition with each other, but being adamant or defiance cannot be the only criteria to label someone with this of the disorder. Again, it can be a part of something like ADHD or autism, that the autism kid is fascinated or he's just engrossed with some particular thing, that he wants that particular because of his sensory issues, he want particular kind of toy, he want particular kind of car and all those things. But again, only being adamant cannot be a criteria for judging any of the mentioned disorders.
Right. Perfect. Dr. Venkateswaran, you talked about ECT and you talked about RTMS. Can you throw light on ketamine? Somebody's asked about the role of ketamine being used in India. I think you have to unmute yourself.
Yeah. For acute depression, now the Maudsley guidelines also recommend ketamine for adult, but adolescents we have to get more evidence, sir. But it has been used. I have not used ketamine, but there are consultants like has used ketamine in Chennai for a treatment-resistant depression in adolescents. But the one problem with ketamine is it requires a setup where we have to monitor vitals and any acute complication due to ketamine, one thing. And second thing is you have to keep using recurrently. Every time they relapse, you have to use ketamine. So long term of ketamine is not yet clear now and is used in adolescents. There are lots of ethical issues. So if you have exhausted all the options, probably consider ketamine. If too suicidal and ECT is not, the family is not willing for ECT, so that time, like probably with consent from the family, we can think of ketamine.
I think even for ECTs for children, when we have to use it, we'll have to take consent from 2 psychiatrists have to
Yes.
certify, and we need to do it. So I think ketamine, again, the role of ketamine in depression in children especially is still, I think, not
Agreed.
well established.
Yes.
And right, thank you. So the next one is Pritam about tryptophan and tetramethylfolate in children. Have you tried it, and if so, what is the dose that you would recommend?
As of now, I have not tried particularly tetramethylfolate or tryptophan to that extent, because again we don't have any preparation for tryptophan, or means I am not aware of any particular preparation which is available for tryptophan. But yes, again tetramethylfolate or folic acid or vitamin B12, methylcobalamin. Again, multiple micronutrients, multiple multiminerals, vitamins can be a causative agent for some kind of depression or some kind of anxiety issue. So definitely, if something or if the patient is not responding to a particular age, particular kind of drug, we are suspecting, looking at his overall lifestyle, that he might have some micronutrients deficiency. So we can generally prescribe all those things, because being into the child practice, we need to generally prefer to the syrup formulation. Whatever we generally use, Bicosul, Biplex syrup is available, or either Ginkgovit, which normal multivitamin or multi-nutrient supplement what we give. I have not used particularly specifically a tetramethyl folate, only a drug which is including tetramethyl folate, because uh, again only specific vitamin B12 or any vitamin deficiencies leading to depression or any mental health issues are not such common. Again, it can be there, but again, means in your practice you don't see that much that a person is having vitamin D3 deficiencies or B12 deficiencies and then landing up with depression. This is very, very rare phenomenon.
Correct. Me neither. I don't uh, have a very, just tryptophan alone is something that is very difficult. Yeah, before we go to the questions in the chat box, I think Dr. Suma has raised her hand. So could you unmute and ask your question, ma'am?
Yeah. So I've actually made the observation earlier. So I am a pediatric rheumatologist. So I get a lot of children referred to me as arthritis because they have various aches and pains. And there's a very large contingent. I would say as much as I see children with juvenile idiopathic arthritis or actual rheumatological problems, I see as many of these children with somatization uh, and usually significant anxiety disorders who are frequently mislabeled by the other professionals, medical professionals they meet. And I see, the issues that I see is translating symptom to diagnosis is a very big issue in common medical practice. And there are many bars to this actually. Many doctors don't, like you said earlier, they don't think that children can have these children. I wouldn't say are formally depressed. The actual, I mean, once at one point over 4 months post COVID, actually, looked up just looked at all the number of patients. We had 50 patients, 50, referred to mental health professionals from my clinic. And I would say about 5% of those exhibited suicidal tendencies, and probably about 10% of those actually required medication, and all the rest of them required, just consultations and with the mental health professionals. Now, the thing is, this is a very, very, very common group. And the problem we face is one thing is that the primary medical professionals are not at all sensitized to thinking about mental health disorder in children who present with symptoms which do not have corroborative signs or any other organic pathology of note. The second thing is physicians themselves having a stigma to diagnosing mental health disorder in children. And the third thing, even more difficult, is particularly orthopedic surgeons who tend to immobilize these children and medicalize them and actually compound the problem. They come with overt CRPS and all after that. Okay, so this is obviously a group that's not covered by your discussion today. So I just wanted a few words on that. The second thing is you mentioned about autoimmune encephalitis. I would like to say more as common as that is SLE and neuropsychiatric presentations too. And we can't count on there being a malar rash in all these. In my practice, less than 50% of them have malar rashes when we diagnose them with lupus.
True, ma'am. I think before the speakers take that question, one more adding to your list are parents. It's even more difficult to convince them because they're more comfortable meeting an orthopedician or a general or a pediatrician who would tell them that it is, even if you tell them it is a rheumatic or an autoimmune condition and it is a lifelong treatment that they require, they are much more contented than you tell them that it is a behavioral disturbance or is something to do with the mind. Then they are taken aback and they don't turn up the next time when you see them.
It's interesting you said that, because what I have seen in my practices, if at the end of my consult, I can convince these families to go and actually meet the mental health professional, and they're convinced by what I tell them, and I tell them to stop the secondary gain right then, the outcomes are excellent. If these fail, then the outcomes are not so good.
Correct.
It's as simple as that.
Yes. Yeah, Venkatesh would want to take the question. Ma'am was asking.
So I'll just chip in. So definitely there lies the role of platform like Marvel's Medicine, where we are discussing all these kinds of issues. Yes, child and adolescent psychiatry, if we go by the history of its induction in India, it's pretty not in fact a decade has been completed with the Neiman's starting its course something around 2013 2014, and now we are into the end of 2024. So definitely still there lies a lot of gap to bridge between the stigma, the misconceptions what the people have. But yes, the times are changing. more and more schools, into my practice, like 7 to 8 years, more and more schools are getting aware. More and more counselors, as it has been mandatory by the CBSE, they are getting aware of the different conditions. They are easily convincing parents that he needs a psychiatrist or a psychologist or a counselor or any mental health professional per se for helping the child and all those things. Secondly, when we talk about the general practitioners per se, I have two, three different aspects. I might sound odd to some of the people. Many of the times, what I feel that people also have the understanding what is going on with the child, what is going on with an adult, but they themselves are reluctant to share the patient with a super specialist because they don't want to get exposed for their knowledge and everything. Again, it is not just a unidirectional kind of thing, blaming only parents and everything, because those who are, like ma'am, you have mentioned, those who are aware, who are critical of the things that the child needs to be helped, that the adult needs to be helped, they are uprightly sending or referring the patients to us. But there are many pediatricians, many physicians, many general practitioners, they keep on trying the antipsychotic the psychiatric medications on their own, and just not guiding the patient in the better way. So it's not like all about that the patient, it's about the awareness in medical practitioners or not. I feel everyone is sufficient with the advent of social media, the awareness platforms what we create, newspaper, motivational videos, and whatever, we all have our social medias and everything. Everyone, to some or majority of the extent, is aware of the situation. It's about the willingness to send a patient to a mental health professional, that he needs the treatment, that he don't have any organic issues, his physical condition is absolutely normal. This is all about the mind, this is all about the neurotransmitter, and that's why you need to consult all those things. So again, this is the again an important aspect what we are making, because again I visit my hometown, which is almost a rural place kind of thing. And to my surprise, when I started visiting it, people are themselves coming, because psychiatry is such a branch where have a you don't have any roadblocks. Like if a child or if an adult is getting aggressive, he's getting agitated, irritable, he's using foul words, he's not focusing on an adult, he's not focusing on his academics, he's hitting someone, so they are also having that mindset कि इसको pediatrician के पास लेके जाके फायदा नहीं होगा, इसको general practitioner cannot treat this, he has something to do with brain or something to do with mind, so it's better that we should consult either a neurologist, neurosurgeon, or a psychiatrist. So yes, awareness is increasing. We are putting a lot of efforts to scrap that stigma, misconception. But yes, the approach has to be from everyone. It doesn't have to be from psychiatrists as well. And like the complex which I practice in, stigma is everywhere. Now, why to stigmatize psychiatry? Like I have a neurologist on the first floor. He has stigma regarding epilepsy. He has stigma regarding stroke. I have a gastroenterologist, so they have their stigmas associated with. I have an oncologist on the top floor, so they have their stigma against the cancer and all. I have a diabetologist, I have an endocrinologist, so stigma is everywhere. So as a practitioner or as well, we need to have a positive approach rather than keeping ourselves engrossed in that stigma world. The world is changing rapidly. Everyone just means you are just away with a 30 seconds reel to reach your population. So I think rather than this stigma kind of thing, we need to focus on the positive aspect of it, and what we can do to make aware as much as schools, as much as parents, as much as teachers about all these mental health issues. And in no time, like Vasant in the initial description has mentioned, that COVID has been a blessing in disguise for all of us, that the people are getting aware and aware about the child issues and everything. So yes, the things are on the changing trajectory, but yes, you need some time for that, because in India, change doesn't change in such a drastic way. It has its own time or patience before the things get in hand.
Yeah, that I think well said, Pritam. Moving on to the next question, uh, Venkateshwaran, if you could take it, there's a thing on what is the minimum age below which one should not consider depression as a diagnosis in children? Is there
So
any
usually,
lower limit?
no, there is nothing, there is no clear cutoff, sir. Usually before 6 years, we'll be very cautious, but as such, there is no cutoff.
Correct. As far as the child is vocal and he can talk and communicate
Yes.
with us, there goes.
Sometimes children with developmental disorder, they can present even at 4 years, sudden onset behavior problem for 1 or 2 weeks. Then we have to take it as a mood disorder. Need not to be depressive episode. We can take it as a mood disorder, but there is no clear cutoff. But generally, it is commonly diagnosed after 6 years when
Right.
they have the cognition.
Just continuing with that, how do you differentiate between depression and symptoms of ADHD?
So the
You
ADHD is
about it.
ADHD is a developmental condition which is going to be a chronic condition. Okay, so they will have symptoms from the very young age, especially hyperactive subtype. But inattention subtype may present little late when their academic load increases. But hyperactive subtype usually from the very beginning, and it is highly comorbid. Lots of ADHD children will have depression. But if you see suddenly all of a sudden the ADHD symptoms either you see it improving, the hyperactivity become very less, the child will be withdrawn, not interacting, then you have to suspect something is wrong. Or sometimes is vice versa, like opposite, ADHD symptoms worsening, further decline in academics, more inattention, performing very poorly. So if there is a clear answer to these phenomena, then probably we have to suspect a mood disorder. But unlike depression, ADHD you will see from the very young age.
And how prevalent is neuropsych testing and evaluation in India?
Sir, unless there is a diagnostic challenge, we generally don't do any neuropsych assessments, or if you suspect organic causes. But depressive rating, we can use rating scales we commonly use in the day-to-day clinical practice.
Preetan, even you rely only if there is any diagnostic discrepancy or a challenge, is then only we go
Yeah,
about.
definitely.
I don't think
Because
it's not a routine thing that we.
yeah. It is almost the same. Again, there are some class of patients like some elite or VIP kind of patients who want something which needs to be documented. They want like after we say that your child is suffering from depression, so how doctor you are saying that? So definitely, as Dr. Venkatraman said, we can go with different neurological testing. We have rating scales. We have some testings like HAMD and some cognitive assessment test and all those things. But again, it is not a very routine practice that we go for the psychological testing as far as depression picture is concerned, unless and until we are unsure about some diagnosis, we are suspecting some psychotic features underlying, we are suspecting some bipolarity or anything which we feel that it is not in line with the diagnostic criteria.
Correct. Yes, ma'am. Munchausen's by proxy is something that we should also look out for. And when you suspect about it, and when you think that the attention is unnecessary and the child is being repeatedly bought, that is something that we really need to look at and not make a rush with making a diagnosis and aiding the parent in their purpose. Somebody's talked about suicides. Yes, I think suicides in especially school children, when we deal with them, uh, both the speakers had talked about it. One thing that I would also go ahead one step ahead is we limit our post suicide when a child from a college or a school is dies, and we should also look into taking in the school children, the child's best friend, the child's classmates, rather than only focusing on the siblings and the family alone. Because many a times the close friend or the classmates, they also go into this grieving process. So that also needs to be addressed, because somebody talked about how we missed two suicides when it happened at Jipma. So I think that is one that I wanted to talk about. The Preetam or Venkatesh, if you could add on
So,
suicides in children.
It's, as you said, sir, like I think you have covered.
Perfect. I think we're done with the questions, ma'am.
Yeah. If you have to, both of you gave a lot of detailed thing, but for a, non mental health professional like me, I'm even more confused than I was before the talk. So, if you wanted to give each of you, if you wanted to give some simple, for want of a better word, tips to a parent, how they how they may be able to pick up depression early, what would be those few things, Dr. Pritam, for preteens, and what would be the few things for them for older children, Dr. Venkateshwaran?
Most importantly, I feel one thing which every parent should notice is change in the behavior. Like, for example, your child was absolutely better. He was having a good sleep, good appetite. He was performing well in academics. He was cheerful. He was interacting. He was playing and everything. And suddenly, last few days, few months, you have been observing that his mood is swinging a lot. He's getting irritable on trivial things. We are getting complaints from the school. The kid, he's not interested in playing anymore. He's not interested in discussing anything or going out, going for a movie, going for a play zone. School counselor has also mentioned that his activity level has gone down. So these are some early warning signs which a parent should look into. And most importantly, which I always say, that a parent can, because the parent has been there from the birth of the child till the time he is looking into, and they are the first gatekeeper who can judge this thing, that their child was absolutely well, and suddenly there are some changes which they also feel which is odd for his overall personality, the kind of child he was. So definitely being vigilant about this change in behavior, change in his activity pattern, the way he was before few days, few months, and now. So I guess these are some early warning signs which a parent should look into.
Yeah, the two things, ma'am, like as Dr. Pritam was rightly said, like it's same in adolescent. If there is a clear onset or if there is a clear impairment, then we have to be vigilant about depression. Okay, the sudden change from the natural usual behavior, that is a clear onset, or if there is a clear dysfunction in one or other domains of life, like academics, peer interaction, family interaction, then probably something is wrong and they have to look for a depressive episode or other psychiatric or medical illness for that matter.
So, what is the first thing that you would advise a parent when they notice this kind of behavior? What is the
They can
first step?
they can contact their pediatrician first because they will trust their pediatrician. So they can contact the pediatrician, ask them what is this, whether they need evaluation. Many a times the pediatrician will be like the first line of contact and they will make referral. Okay. In West, like this is very common model. Meet your GP, meet your primary care, discuss about the symptoms, then go further up. But if the symptoms are very visible enough, they can directly contact mental health professionals. But many a times it will be through pediatrician or a general physician where they come to a mental health professionals.
So, in India, among my acquaintances or whatever, I have seen this sort of reluctance to meet a psychiatrist. People prefer to go to a so-called psychologist or whatever. They said, "Can you refer me to a counselor? Can you refer me to a psychologist?" Even before a diagnosis is made. So, how do you work around this problem?
Yeah, ma'am, like they are scared that we may start medication, but this is a problem and it will it is a multidisciplinary approach. Okay, it's all are important. Okay, all the arms are important in the multidisciplinary team. Okay, there are some situations where only counselor cannot help. There are some situations where a simple supportive counseling can help, but this depends on the clinical picture and what is the clinical situation warrants. Yes, this is a problem, and as a medical community, as a whole, we have to educate parents to overcome the stigma and get help.
Thank you. Radhakrishna, we are almost out of time. You want to say something?
Yeah, interesting conversation indeed. Because I always felt I'm a surgeon, and I thought my science is a pure science where blood tests and CT scans will say that this is the problem and this is the treatment, and I always felt psychiatry is not a complete science, where you don't have definitive investigations to try, diagnose, and treat. Having said that, I have a few questions this time. The one is. First question I want to know is there a gender difference in this particular condition? Do girls have different baby girls and adults and girls have a different set of problems as compared to boys? Question one. Question two is I've seen actually these things happen from very close quarters, and when adolescents in trouble, do they get drawn towards the opposite sex and try share things, or do these relationships get complicated? Any one of you can.
The general difference in childhood, I think Pritam can add up, but there is no clear gender difference in childhood depression. But adolescent, there is a slight preponderance to females. Female adolescents has little more incidence of depressive episode, and they generally say in male it is more severe episodes. Okay. Your second question probably you are talking about sexualized behavior, if I'm right.
No. You see, the adolescence is the time when the boys, girls meet, and I've seen in people sort of confiding in each other and crying in each other's arms and all that, unable to find out what is wrong with them and all that. I know you get the question, but if you think that we should cross over, I'll just come back to Vidya's question again in a more specific manner. As a parent, I do not know whether to take a child to a psychotherapist or a psychiatrist. One, is it that if I take a child to a psychotherapist, that person will refer to the psychiatrist, vice versa? Do you have that system? They can identify that, okay, this child will require a definite psychiatric help.
A well-trained therapist will definitely do that, sir. I think if the system is proper, and if the therapist is open to in developing the rapport and treating the patient holistically, definitely the referral systems are in place. It is a multidisciplinary. We do it both ways. I have received referrals from therapists saying, my job is done here. I think he or she requires your attention. Please help us, even in making a diagnosis. So, and setting the ball rolling. So both ways it does work. That is my experience so far.
My next question is, psychiatry is very difficult to get appointment. I do not know. It's very, very difficult. First thing. Second thing is, why do children keep changing their psychiatrist so often? When it comes to a surgeon or a physician, most of the patients will stick to one person. But the child will say, I don't like this psychiatrist. I don't like this psychotherapist. The very, very few children will say that I like my therapist or I like my psychiatrist. Why is it that?
I like
They
to
keep
differ, sir.
changing.
Any chronic illness has this problem, sir. Be it psychiatry or rheumatology or neurology, if it is chronic, they keep changing because it is going to be there for a longer time. It is not only psychiatry. All the physician and the surgeon, it is an acute problem. Like they come, you cure the problem, they'll go very happy. They no need to change. But in chronic illness,
Don't you cure the problem?
no, sir. Like we are not God.
Now, the next one is, how much does online treatment help? Because the online has become a very big thing now, and I've seen psychiatrists says your child will get a slot on 23rd of February at 7 p.m.
So basically, sir, there are 2-3 dimensions to it. It depends on the comfort level of the treating psychiatrist as well, and the comfort level of the parent and the child as well. But major, like if I mention my case in the initial COVID phase, I would used to indulge, particularly for child and adolescent population. I tried to have an online consultation 2 to 3 times, but it doesn't work because again in psychiatry, it's all about your personal interview. It's about your clinical interview, how you are maintaining eye to eye contact, how you are expressing yourself and all. So as far as child and adolescent population, it's really difficult to judge all those things on an online perspective. Yes, once you are in a couple of consultations, you are sure about the diagnosis, the child is also comfortable. So yes, for follow-up, it is a good tool to save time, to save the travel, to save everything. But at the initial consultation or at the onset, it is bit difficult. Yes, in some cases, like if a US patient, UK patient wants to have a second opinion with all their reports and investigation, that can help. But again, a 7-year-old boy just having an online interaction with you, you cannot judge anything with that, because it's multiple things which needs to be judged when a person is sitting in front of me. But again, it depends of the comfort level of the psychiatrist, the comfort level of the parents, and overall thing. I have many of my friends who are doing only an online practice. They don't have their clinics as well, they don't have their OPDs as well. But again, it depends. It is very subjective on the comfortable level of that. But particularly if I have to mention my case, I'm a bit uncomfortable, particularly for the child population at least, because it doesn't give you any particular idea about what is going on, what is underlying physiology, underlying the things which are being there. So I have my reservations, particularly for the child population for that.
My last question is, why are psychiatrists so few? Are their seats are very less, or there are not many takers? And why is a rare specialty?
First, it's not rare anymore, I
Yes.
feel. Yeah, when you talk about the ratio, especially in our state and in India itself, I think we meet the criteria of the required number.
But they say there are no psychiatrists, child psychiatrists in the rural sector, where the need is much.
The child psychiatry is, as Pritam has mentioned, it is a very
Super
new
special.
field. It's only a decade-old field. So the people are coming, like every year, like at least 10 to 15 are coming from all over India with some training or a qualified degree in child psychiatry. So it is
And
quite.
psychiatrists per se fill that job as of now. I think.
Yes, yes. The psychiatrists, so many psychiatrists are qualified and experienced enough to handle children. So
Now, one last question with your permission. Did all of you took psychiatry by choice or by chance?
No, as far as my submission is concerned, it was my choice only to go with psychiatry. So there was not luck by chance, it was pure choice of mine.
I had a choice between anesthesia and psychiatry. Sorry, Vidya ma'am, I didn't want to take anesthesia. So I took psychiatry.
Good thing, Vasant.
They're like they're just poles apart, like oh my God. Not at all a difficult decision.
Yeah.
Dr.
Nice
Pritam.
listening to you people.
Yeah.
by choice,
Okay.
man.
Okay. So Meghana, you have your camera on. Did you want to say something? Meghana Kammampati. You turned your camera on. Did you want to say something? If yes, okay, your camera's off. Dr. Gautam Rai, your camera was also on and off.
Samsung, someone wants.
And Dr. Gautam Rai's camera was also on and off. So if you want to say something, please go ahead. And Samsung SM, we didn't get your name. Your hand is up. Would you like to say something?
Yeah, I just wanted to know, while discussing suicide among youngsters, does having a moral science classes or a religious background result in a reduced rate of suicide and suicidal thoughts?
If we look at the moral science or the religious aspect of it, to some extent, it can definitely help to rationalize your thought process, to cognitively make you better. But again, in our psychiatry, when we talk about religiosity or the spirituality, anything in excess can lead to multiple mental health issues can into that way. Again, there are multiple studies which has been already done going on about the role of spirituality, religiosity on mental health problems and all those things. But until and unless it is done in a normal way, and to some extent in a limited way, it can definitely help you to deal with your anxiety. Again, mild kind of symptoms, what you can make out, mild depression or subsymptomatic, some subsyndromic kind of depression. In that cases, it definitely helps. But again, in moderate and severe depression, the role of all these things, it's debatable.
No, the reason I asked is every religion and every moral science class, they used to say that taking a life is wrong. Giving a life is not in one's power, so taking a life is wrong. And this is, if this is instilled in the school going age, it makes a very big difference to the way you look at things. And nowadays, I find that, at least I learned that moral science education is not there in the government schools anymore. They removed it. One period is being saved per week.
Yes, I think what I mean, the lady who spoke now is probably trying to say that, moral science didn't into your head that suicide is a sin, and so because it's a sin, it might reduce some people from doing it. But Vani, you had your hand up.
Yes. As far as I know, I'm not a psychiatrist, but generally, if you have suicidal tendency, you have major depression. And whether you have moral science class or don't have moral science class, once you have depression, you will have suicidal thoughts. I feel very strongly about this, and thank you for the speakers for speaking. I have been a victim of adolescent depression, which has been missed. And in my time, so many years ago, I would hate the psychiatrist. The psychiatrist will never refer to the psychologist. And I'm so happy that 30 years on, our children have a better life. Going to the psychiatrist is not a stigma. Mental health is not a stigma. The younger generation talk openly about mental health, but in our generation, it is all hidden, and it was very difficult. And especially talking about suicides in JIPMA, there was a suicide when I was in second MBBS, and there was a suicide when I was in final MBBS. And I was a very bold girl from Dehradun, and I used to think that suicide occurs in cowards. That's not at all true. And this is just a thought. Maybe, I don't know if I missed. I was listening to most of it, but there was no power. I thought, I may be wrong. Did you deal with mobile addiction and drug addiction? And does that also make a big difference nowadays to depression in adolescent?
Vasant can comment again.
Yes, ma'am. I think we didn't touch upon addiction as such, but yes, if the addiction definitely leads on to a lot of behavioral disturbances in the child when you confront him from using it and all that. So rather than it precipitating a depressive episode as such, it is more of behavioral challenge that we look at, the behavioral addiction that we talk about. The changes are more behavioral, and that requires a separate set of things.
And I also want to answer one question, that the patient never wants to go to a psychiatrist, okay? They may not mind going to a neurologist or whatever, and they generally hate the psychiatrist, okay? And so just jokingly, my most favorite psychiatrist on the panel was Vasant, that's just in lighter vein. So the perception of the patient also to the psychiatrist. Like if you are talkative and the psychiatrist doesn't talk, you don't like him. So I just liked your smile, Vasant, and I wanted to
thank you so much.
Thank you.
Thank you.
And I love Venkateswaran is my husband's name, and I love Pritam's accent. Thank you very much. It was an amazing discussion, very much needed for these times. Thank you.
Thank you, ma'am, for the acknowledgement and appreciation.
So thank you, everybody, for staying way beyond time. And thank you, Dr. Ramesh and Dr. Vasant, once again for putting together the speakers. And it was, you were very patient with all the questions, and you lucidly answered, and hopefully we made a small difference in the way childhood psychiatric disorders are perceived among the general population. As psychiatrists, we are already well informed, but doctors and others also, hopefully we have gained some insight into this problem. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.